So anyway, the microperimetry really is the only way of providing this ability to test certain retinal locations and really follow them well over time. Okay, so the Nidek system uses an infrared system for imaging the retina during the testing, because you can't use a regular fundus camera. The illumination is too bright and you wouldn't be able to do testing of stimuli over it. And then it's a non-mydriatic color fundus camera, so you take a fundus image and you can register the two together automatically. One of the really nice features of the MP1 is it automatically tracks specific features of the retina in real time. So what you do is you first define the points you want to test, and then you put the patient in, you freeze an image, and you identify first the disc, because they do a reliability thing similar to what would be done in a Humphrey, like a false positive effect, so they have to know where the disc is. But then you identify what they call a region of interest, which is a region that has enough characteristics like blood vessels going through or vessel bifurcations or whatever, so that the computer can then track the retina. And what happens is it tracks the retina, and if the retina moves, then the stimulus that is going to be presented is moved to compensate for that eye movement. So what you end up getting is really retinally correct testing, even if there's poor fixation. And you also get a display of fixation and a way of measuring fixation stability. So this is one of my patients with geographic atrophy. Actually, no, I think it's easier this way. And I've circled here the area of the atrophy. And what you can see is that this is just doing for a dense scotoma. In other words, it's a 0 dB stimulus, and I'm just doing a grid of points. Do they see the brightest stimulus or not? What you can see is this very good correlation of the areas that were not seen, which are the open squares, to where the geographic atrophy was. Now that in itself wouldn't be so remarkable, but what's amazing is this patient was starting to erode through the fovea, and maybe he was distracted as well, but for whatever reason, these little blue dots there are what his eye was doing. In other words, where he was putting fixation during the testing. So you can see that he was all over the place here, and yet the computer software did an excellent job of correcting for the stimulus position with all these eye movements, so that it really mapped out where the atrophy is. You can use Humphrey-like testing patterns that are provided. You can create your own testing pattern before you begin testing, either by starting from an existing pattern and supplementing it, or by creating your own pattern. And you can add additional points manually after you've finished testing to refine your testing, and I find that a very, very valuable thing. Okay, so the way I generally do it, excuse me one second, is you choose the pattern that you want to test. You choose the beginning stimulus intensity and size, and the size of the fixation cross. You specify what kind of strategy you want. That is, do you just want a fast measure where you just do everything, let's say in at one stimulus level, or do you want something that's going to give you a finer threshold? And you can specify the strategy like a 4-2, which means that if you don't see it, it increases the brightness by 4 dB. And if you see that one, then it comes back up 2 dB, and it goes in that staircase procedure till it determines what the sensitivity is. You can also use, they have even a finer one, 4-2-1, but the problem is that these are very time consuming, and I've never used that on here. Okay, you line the patient up, as I said, you capture the image, you click on the optic nerve for later false positive checking, and you define the region of interest. I don't know, honestly, I'm not necessarily advocating that you do it this way. I have, where I am, I end up being the person doing a lot of this testing, although I'm starting to train someone now more. So, and I have very specific needs for what I want to test. So the thing is that I find, for me, the so-called semi-automated mode is the best thing. What that does is you define a grid of points directly on the fundus image. and I set things so I use the fast algorithm, and I'm often just looking for a dense scotoma, so I set it at 0 dB, the brightest, and then I see what I get in my grid, and then I can add points as I need to. And the advantage is that it's much faster than a standard thresholding technique, and it's very easy to set the density of the points. You can make a very dense grid or a very sparse grid, and you can define where you want to test very effectively. You just click and draw a polygon basically surrounding where you're going to test, so that you specify where you need to test, and you don't have to test extraneous points. The limitations of the MP1, the main one to me is the fact, and this is, you could say that the rodent stock, one of the advantages is it's not hard to get through a small pupil and to get an image. It's a little more difficult with the MP1. I would like, in an ideal world, to be able to have somebody do an MP1 for me and present it to me before I see the patient. And then when I'm going to evaluate the patient and we're going to do low vision training, and we try to get a lot of that done all in one visit, I have that information before me. The problem is that many elderly people have small pupils, and it's often hard to get a good enough view so that you can find the region that the MP1 can track. If it can't track, you can't test. So what I do is, if I can't do that, then generally we can get at least a color image, and we can often do enough to get just a fixation map. So, because in a lot of these cases, really the main thing I want to know is where fixation is relative to the fovea. So that's one thing. And obviously, you could think of it as I'm spoiled in that respect. I don't want to dilate the patient, but obviously you can dilate them, and then everything becomes much easier, and you can do that after the training. The other thing is that the testing, if you use a regular Humphrey pattern and you use threshold perimetry, it takes a long time. And again, because I'm the person doing it, I customize it for what I want to do. I think if I were having a technician do it all the time, I really would have to have them do more of a grid similar to a Humphrey to define where the abnormality is. But as I said, I generally am looking for just for dense scotoma, and then I'll go in and do threshold testing in the area that I'm interested in. It's useful when there's no visible lesion present. In other words, if I see an area of atrophy, I pretty much know where the person isn't seeing. But in a situation like this, which is somebody who has optic nerve disease, looking at the fundus, there is no way to figure out what's going on. And in addition, you don't know, even if I could get a sense of which side the person's having a problem on, you really don't have an idea of how close does it come to the fovea and so forth. So here this person has a sort of an arcuate scotoma from optic nerve disease. And the MP1 theoretically and potentially is the ideal instrument for tracking the course of the disease, like for clinical trials for retinal disease, because first of all, when you do a specific pattern of testing, there's an option called follow-up. Follow-up means, let's say the person comes back 6 months or a year later, you can test the same retinal points a year later that you tested a year before. The way that's done is you sort of start setting up the microperimetry the same way that you would if you were, as though you were starting a new test, but then you register the image you captured with the image from the year before, and then it corrects again for stimulus location and puts the points on the retinally correct location. And as long as you choose for your region of, well, as long as you, let's put it this way, as long as there are things that can be tracked that are going to be stable, like for example vessel bifurcations, you wouldn't necessarily want to track an edge of an atrophy, which may change. But as long as you can track something that's going to be consistent, there should be no problem. It doesn't matter if fixation changes. The points that are tested they're not tied to fixation, they're tied to the other